Today I will talk about the research progress of Claudin 18.2 targeted CAR T cells in patients with advanced gastric or gastroesophageal junction cancer. Different with ADC. Different with ADC. The CAR T cell therapy is not there are not very much the data from the CAR T cell therapy. So I will mainly talk about a trial from this CT41 and ST01. I also present this result yesterday on the ASCO meeting. This is a pivotal study. Compared the Claudin 18.2 targeted CAR T cell, also known as Cell, against the treatment of physician's choice for previously treated advanced gastric or gastroesophageal junction cancer. As a background, maybe we know Claudin 18.2 is overexpressed in various gastrointestinal tumors, especially in patients with gastric or gastroesophageal junction cancer. And it has emerged as a promising therapeutic target. And maybe you know a novel drug called the zolbetuximab has been approved in USA, in Japan, and in China, which is a monoclonal antibody targeted Claudin 18.2. Cell is a Claudin 18.2 specific CAR T cell therapy and has shown encouraging efficacy in previously treated patients in a phase 1 clinical trial. And here we will report the primary result from the phase 2 randomized trial. This is an open-label, multi-center randomized control trial conducted across 24 centers from China. Patients with Claudin 18.2 positive, HER2 negative, advanced gastric or gastroesophageal junction cancer who failed to at least 2 prior lines of treatment are randomized at 2:1 to receive the cell infusion or receive the treatment of physician's choice, including apatinib, paclitaxel, irinotecan, or nivolumab. The treatment model is very different in these two groups. In the cell group, the patient will receive once or twice infusion of cell, and then into the follow-up of the survival and the safety. But if the patient in the treatment of physician's choice group, the patient will receive the treatment weekly or twice weekly, and then. The patient in the TPC group are allowed to cross over to the cell group after the infusion, after the progression. And in this study, Claudin 18.2 is defined as moderate to strong expression in more than 40% of the tumor cell, which is different from the definition before in the Spotlight or Glow trial for the zolbetuximab. And in this study, the stratification factors include prior anti-PD-1 treatment, liver metastasis, or ECOG status. And the primary endpoint is PFS assessed by independent review committee. And the key secondary endpoint is OS. This is the statistical consideration for this study. For primary endpoint PFS, HR of 0.55 corresponding to a 55% risk reduction with cell versus TPC group was hypothesized, and the median PFS in TPC was 3 months. The event goal for PFS to achieve 85% power at one-sided alpha of 2.5 was 114. The sample size was 150 based on an estimate of 114 PFS events with a 15 dropout rate. And for key secondary endpoint OS, HR of 0.56 was hypothesized, and the median OS in TPC was 6 months. The event goal for OS to achieve 80% power at one-sided alpha of 2.5% was 107 if the PFS analysis achieved positive. And the data cutoff date was October 18, 2024 for PFS. And the final OS analysis was conducted at the same time as 105 OS events were reached. The alpha level of 2.5% was recycled to the final OS analysis as PFS was tested positive. At last, 266 patients was screened, and out of this, 156 was randomized, which is the ITT population for this study. And ultimately, 88 patients received stem cell infusion, 48 patients received TPC, which is the MITT population for this study. And there are 20 patients in the TPC group crossover to the stem cell after progression. We can find that the baseline characteristics are well balanced. We can find that most patients have diffuse or mixed Lauren type. There are most patients received 2 prior lines treatment, and 2/3 of patients have peritoneal metastasis at baseline. This slide shows the primary endpoint. We can find that this trial met the superiority PFS endpoint in ITT population assessed by independent review committee. The PFS was 3.25 months in stem cell group versus 1.77 months in TPC group, corresponding to a hazard ratio of 0.366, with the p-value was less than 0.0001. As a key secondary endpoint, the OS for ITT population was 7.92 months for in stem cell group versus 5.49 months in TPC group, with a HR of 0.693, and the p-value was 0.0416. And actually the OS didn't meet the scientific significance because of the design of the crossover. PFS benefit of stem cell was obviously observed across almost all pre-respect subgroups. And in the MITT population, we can find that the PFS assessed by independent review committee was 4.37 months in stem cell group versus 1.84 months in TPC group, with an HR of 0.304. And the OS in MITT population was 8.61 months for stem cell group versus 5.49 months in TPC group, with an HR of 0.601. Because there are 20 patients in the TPC group subsequently received stem cell infusion, so the OS was underestimated. So we do a OS analysis by RPSFT model to remove the influence of the crossover. We can find that the estimated median OS was 1.8 to 2-fold longer with stem cell versus TPC, providing a 53% and 63% reduction in risk of mortality in the ITT and MITT population respectively. This slide shows the reduction of the tumor assessed by IRC. The objective response rate was 30% for stem cell group versus 4% for TPC group, and the DCR was 70% versus 24%. And assessed by investigator, we can find that the objective response rate and the disease control rate was obviously improved in patient. Let's talk about the safety. in this slide, we can find that there are more common TEAE and TRAE in set cell group. But the two patients who experienced the discontinuation of the treatment are all in the TPC group. But all the CRIs are all in the set cell group. This slide shows the details of the TRAE. We can find that the most common TRAE is hematological toxicities, which is considered to be related to the lymphodepletion chemotherapy before the infusion of such cell. And as a doctor, we all know the hematological toxicity is very easy to control. And another common adverse event in the cell group is CRS, cytokine release syndrome. But the main CRS are grade 1 or grade 2. Little patients, 2 or 3 patients experienced grade 3 CRS. And the AES model is very different in the two groups. In such cell group, because the patient receive the treatment once or twice, so all the TRAE are occurred in weeks or 2 weeks after the infusion of such cell. Then the PFIs, then the patient will have a very, very good life quality in the PFIs. But in the TPC group, the patient will receive the treatment very, very frequently. Although the AE is less difficult, but they will experience the adverse event every times after the treatment of the TPC. As conclusions, the such cell demonstrates significant PFIs improved and clinical meaningful overall survival benefit in patients with gastric or gastroesophageal junction cancer compared to standard of care. And we observed a measurable safety profile alongside long-term benefit in many patients. And another meaningful point in this clinical trial is this trial expanded the percentage of Claudin 18.2 positive patients. We have mentioned that zolbetuximab has been approved for patients with gastric cancer. But for zolbetuximab, the Claudin 18.2 positive patients only count to 35% to 38%. But in our clinical trial, if we definited the Claudin 18.2 positive in this clinic as the criteria in this clinical trial, the patient percentage will increase to 60%. So it's very important. This data suggests that the such cell could become a new treatment option and provide a strong relation for continual investigation of such cell in earlier lines of treatment for patients with gastric cancer. Thank you.